All right. So today I'm going to talk about two things that are interesting in our COVID world, which are Medicare Advantage patients and telehealth, and really a little bit about our different plans that we have out there that include our Medicare recipients and what's the difference among them. And also, we're going to talk about the differences of telehealth and what's been going on with our senior population, and the pros and cons, of course, of being in this world and going through the motions of helping them continue on with their health care. So the first thing I'm going to be explaining and talking about is the difference between value-based care, managed care models, Medicare Advantage. Of course, we're going to talk about telehealth and both telehealth and Medicare Advantage. So, of course, value-based care is really a dire shift from fee-for-service that we're very used to, and of course our providers are very used to the model of rewarding practices for quality and effectiveness of care. We focus a lot of value-based on this triple aim theory, which is reducing per capita cost of health care. We improve the patient experience of care, and of course, all that is improving health of our population. So that's really the aim. Now, interesting enough, the value-based care model is really evolving, and we have currently about 22 million Medicare beneficiaries that are enrolled in these plans. Now, yeah, the one that was most popular and you've seen perhaps throughout the Southeast is managed care, which is a delivery system, healthcare delivery system that does a correlation of managing costs, utilization, and quality for those tenants that are part of the value-based medicine world. So the basics of managed care is, of course, rather than being paid for each service, payments being made based on quality and efficacy of care. Key terms that you'll hear during managed care, which is contracts producing a full risk, partial risk, capitation, pay for performance, pay for value, value-based care, ACOs, and bundled payments. So all that is encompassing the different aspects of managed care. And typically you see this a lot in our primary care institutions and really large FQHCs. And now more and more specialties are getting involved in this. Your gastro groups, cardiology groups, and rheumatology are some of the ones that I know that they're very popular with. So there's different models of managed care. First one being ACOs, which could be physicians, hospitals, and they produce kind of and really incorporate their own network. It started in 2011 with 32 ACOs, and now it's evolved to about over 600, close to 650, if not growing more. And really they focus on accurate risk adjustment, which is the best way to find generate savings. We also have the commercial risk and ACA plans. This has to do with risk adjustment, allowing plans to change lower premiums because risk is based on scope and not health status. And once the ACA was in place, risk adjustment really became necessary for commercial plans. Providers partnering with both the ACAs and commercial plans to deliver information and ensure a cooperative way for both to succeed. And finally, our managed Medicaid, which these are Medicaid contracts with managed care organizations for a capitated cost per patient. About 32 states have privatized Medicaid, and risk scores, of course, are used to determine premiums. Now, when we talk about Medicare Advantage, these are the plans that perhaps you've seen advertised, which are Humana Medicare, your United, also AvMed Medicare, Blue Cross Blue Shield. So different commercial plans have really focused on Medicare Advantage. The model has been really growing steadily since '99. 34% of our Medicare enrollees are in an Advantage program, and it's predicted, of course, to grow and rise to probably close to 50% by 2028. So a little bit about how it's evolved. Since '99, they started off, Medicare beneficiaries started off at 18% of them enrolling in Medicare Advantage plans. And by 2018, we're now at 34%. And of course, every year we're inching and growing leaps and bounds. So here we have kind of per the US, which states really have a heavy penetration. Of course, we have Florida with 43%. Minnesota is really the top at 56%, Oregon and Hawaii. The rest of the states are slowly creeping along. However, it always remains to be seen how fast because of the Medicare demographics and population within each state. So telehealth, introduced by Medicare with the Medicare Modernization Act of 2013. And as you see, we have really different definitions of what telehealth is. We have e-visits, which is really encompassing our communication with the patient through a portal. We have remote patient monitoring, which is a proactive approach of monitoring our patients' needs as far as BP checks, EKGs, and that sort of physiologic information. We have telehealth visits, which are our popular virtual visits that we've been conducting kind of face-to-face over a video method. We have our telephone visits, no video involved. And then we have our virtual check-ins, which end up being a 5 to 10 minute, just, you know, how are we doing today? And also includes, you know, to be very brief. So, as you know, telehealth during COVID has been quite interesting. It's taken us so many years to get to this portion, but it used to take as many years as about 2 to implement. And we've had really a lot of institutions that have been up and running, can be up and running in a matter of days. There's a medical group out in Oregon that went from 700 telemed visits per month to 70,000 per week. Of course, that depends on the population and the, you know, the access to technology, but I think that was quite eye-opening. UpDoc survey found that about 2,000 respondents of 42% have used telehealth during the pandemic, and 91 of seniors had a favorable experience, which that's really great, and 78% are likely to use it again in the future. Very encouraging. So here's kind of a difference between 2019 and 2020 as far as telehealth. The comfort level has increased. Of course, the program participation has increased. Many patients were very leery, especially our Medicare Advantage population, of going the telehealth route. And we'll talk about the pros and cons in a minute. But they've really taken to incorporating their family members and other people involved that can help them through the process. So that's been very encouraging to see as well. So now that we know that we had relaxed guidelines, as you know, when COVID started, all these barriers that we had really were no longer. CMS waived certain copays, certain amount of visits that they denied telehealth access to were now expanded. Even hospitals now can bill for outpatient services and bill Medicare for telehealth services. We expanded CMS expanded the audio-only phone procedure, which was encouraging because a lot of our seniors just didn't have the technology. They added a lot more services for reimbursement under Medicare. FQHCs, of course, were now being reimbursed for telehealth services. And CMS waived the video requirement for certain evals and management services. So the benefits, perhaps you know them already, which is it can calm the fears. It really limited the exposure of being on site, both to the patient and to the staff. It increased our population as far as how many people can we see during the day. Reaching out was imperative. It was time-saving and convenient. And it really improved the provider productivity to continue with this coordination of care. So, of course, some of our challenges were technology access, our patient privacy and HIPAA. We had, in the beginning of COVID, a lot of people using applications that were not HIPAA certified and ended up being hacked, one of them being Zoom. Our workflow challenges, you know, how do you get the patient to join into the call? Education, of course, of this is something brand new to the patient and how to get them on board. Visit limits. Few conditions are, of course, better done in person than telehealth, so those were some of the challenges. So telehealth and Medicare Advantage. The expansion has been quite eye-opening too, from 2013, where it was introduced, all the way to March of 2020. As soon as CMS relaxed those regulations on telehealth, it really took off, and it really saved a lot of negative kind of feelings about telehealth and really opened and expand that process. Now, when we're talking about basic value of HCC coding, this is really the a very quick analysis of when you are doing HCC coding for Medicare Advantage, what it looks like with barely any coding involved or review, to some coding and conditions coded and reviewed, to all your conditions coded and reviewed. So the yearly revenue is substantial from this 76-year-old female with no codes coded, being a 5418 mark, to a 16,573 mark if everything is recertified and followed through. So for when we talk about a poor HCC documentation for televisit or telehealth, this is kind of an example of what not to do, which is very brief, minimal details. And when we talk about good HCC coding documentation for telehealth visit, this is really a good example of, you know, what to include, what the verbiage and how it's expected, and the assessment of plan of how to follow through. So just like in face-to-face visits, there are certain expectations of what can be improved on. I know in the beginning, it was a little daunting for the providers to know what really was good documentation for telehealth visits. But as we continued with their education, they quickly realized that they can provide a lot more details than they were doing. Thankfully, telemedicine is here to stay for our seniors. We have implemented for many organizations out there that have really taken to this process. And seniors really used to be a lot more technology challenge, but we see them using a lot more of your face-to-face type of visits and consultations, as well as when they, call up their grandchildren, they're more used to a FaceTime communication. So they really eased into this process to do the same with their providers. Okay. I just added this slide so in case you wanted to take a look at more resources and more information regarding telehealth services for Medicare Advantage patients. And finally, this is the end of our presentation. If anybody out there has any questions, now is the time. Okay. I don't see any questions or any chats going on, so we'll conclude this presentation. Thank you very much for joining. I'm sure Jan is going to produce a recording of this to send it out to all the participants, and we look forward to the next insights. Thank you all.